Thank you, Andy, for the kind introduction. Good morning, everybody. I'm going to talk about the CDG biomarkers and newborn screening. So CDG biomarkers is an easy topic for me since I'm a lab director. This is what I do for a living and using biomarkers to diagnose CDG in the lab. Newborn screening is new for me. And unfortunately, newborn screening CDG is also new for the public health community, and most of them never heard about CDG. So where do I start? Of course, tell a story. So what is CDG? So every day we live with many different sugars, to name a few: fructose, mannose, xylose, fucose, ribose, galactose. And we heard about essential amino acids, we heard about essential fatty acids, but we never heard about essential sugar. Why is that? Because we can make, as a human, we can make any kind of different sugar that we want from the glucose. So if you have a child that cannot make any of those sugars from glucose, then you have a CDG. Of course, we spend a lot of energies to make different sugar. We are not going to burn them for energy again. What do we do with them? We put them together, assemble into a sugar tree, which we call N-glycan. So if your child cannot put different sugar together and make a sugar tree, that's a CDG2. So by that definition, by that story, is newborn screening CDG new? Actually, it is not new. I may argue about it, because everybody think about newborn screening, you think about RUSP. RUSP is standing for Recommended Uniform Screening Panel. And if you can put a condition on the RUSP, then many states in this country are obligated to newborn screening for it. So that's our ultimate goal, is put CDG on the RUSP. So how we get there? So I pull out the very first publication about RUSP. So there's a list of conditions that is evaluated by Newborn Screening Advisory Committee. That is 2006. So on that list, we actually can identify two CDG. So one is a deficiency in GOT enzyme. So what does GOT enzyme do? They are used to make UDP-GAL. So by now, everybody here knows UDP-GAL is an important building block for glycan. So if we cannot transport UDP-GAL into the Golgi, right, we have SLC35A2, that's a very severe CDG. So GOT, by definition, is a CDG. Why it is not called CDG? Because it's very old condition. It is discovered in 1930. When was CDG coined? That particular term is not coined until 1997. So GOT is almost 60 years older than us. That's why they are not known as a CDG, but GOT is screened in every state in the United States. And in addition to GOT, there's another CDG that is on the panel. That is CDG1B. So it's actually scored pretty good. It's actually higher than many LSDs now on the newborn screening panel. So why is that? Because the treatment for CDG1B is highly effective. So you have a patient that with liver failure put on the liver transplant list, you give them mannose, they come off transplant list, and they live a normal life. So that is so impressive. Even in 2006, that is 8 years after people know about CDG, this one already made into a consideration for newborn screening. So newborn screening CDG is not new. So unfortunately, that GOT was screened using an enzyme method. And if we are using a functional biomarker to screen for GOT that is shared with other CDGs, we would have already newborn screening CDGs today. because enzyme is one per condition, but if we look at the end product, which is glycan, then we can screen a lot of CDGs. So can we do that? So I was tasked to look into that, and in the past 3 years, we do develop a method that we can take a 3 millimeter punch from DBS and extract the glycans of the DBS and derivatize it, put tag on it, and run down mass spec. So this method is fast and high throughput. That means within 30 minutes, the sample prep is done with a 96-well format. And then the run on the mass spec is 2 minutes per sample. So in a medium-sized state such as Georgia, such as Minnesota, the birth rate is about 20,000. So we're talking about 2 to 3 plate, and we can finish all the newborn screening within a day. So this is compatible with how the workflow works in a newborn screening lab. So this is the slides that is the most important slides for this talk. This is validation of glycosylation biomarkers in the archived newborn screening cards that retrieved from known patients. So many of the parents here generously donated their baby's newborn screening card, and I was able to find glycosylation changes and validate this method on all of them. So we use 3 biomarkers for type 1, and they are increased, all of them are increased in PMM2, interestingly, in one of the ALG13 female. So this is also an X-linked condition, very, very difficult to diagnose when the child is older. So I have 2 newborn screening cards come from this ALG13 family. Both affected child carry exactly the same mutation. So I was very happy we can readily diagnose at least one of the patients from California, and also we can diagnose the other one. The profile is slightly milder, but it was obvious to pick it up. So that is convincing me that at the 24 hours of life, not only we can diagnose CDG, but for certain CDGs, this may be a very good, maybe even a best diagnostic window to pick these conditions. So we also pick up SRD5A3, and this is a card come from Canada, Ontario. So it was not easy because Ontario, they don't save the newborn screening cards in the -80 freezer. Instead, they put it into a non-climate controlled storage place. And, but thanks to their cold winters, we were able to elute some blood of this more than 10 years old poorly stored card, and able to diagnose, confirm the diagnosis on this card. Another one we confirmed is MPD1, extremely rare subtype, and I'm very happy that we can find changes, and the changes we see at 24 hours life is actually greater than what we usually see during the routine visit. Another interesting one is I retrieved a galactosemia newborn screening card from Pennsylvania. The reason I was able to retrieve that is because this is a baby come with borderline reduction in GALT enzyme, and the total GAL, the metabolites, is completely normal. So in Pennsylvania, we want to do a good job. So we do 2 tests for newborn screening galactosemia, and both of them are inconclusive. And the baby actually has classic galactosemia. So when we have the baby in the hospital, baby was sick. So we were very surprised that newborn screening show us like not important, inconclusive, and turn out to be a real. So I was able to convince newborn screening lab because they scared too. And we confirmed the diagnosis in the newborn screening cards. Actually, the glycosylation is quite impaired in that patient. And we also successfully retrieved 2 type 2 CDG. So here we use 3 markers One is a monogal that is evaluated under glycosylation. One is monosilation to evaluate the undersilation. So we got a newborn screening DBS card from a patient with ATP6, AP2 deficiency, and also a family with PGM1 CDG. So I'm particularly very grateful to that family because we really want to newborn screening PGM1, and I needed this data for the grant proposal, and we were able to get the cards 2 months before we submit the grant proposal. So this study convinced me that our method is robust. We can separate CDG from the normal controls, and N-glycans are very stable, and they survive after decades in the storage. And 24 hours of life is actually a very good diagnostic window for CDG. So once we have a method, we have a strategy, and we want to do it, so I go back to newborn screening community and try to make new friends and hear what they want. Right? The first of all, they want it to be a treatable condition. That's understandable. They screen more than 1 million babies, and they want to be meaningful. Okay, we can do that. And the second is they want a well-established natural history. So most importantly, they want to know the prevalence. Right? For new conditions, it's actually very difficult for us to know exact prevalence, because they're usually done by surveying every hospital that ask all the hospital how many cases you pick up each year. That take a while to materialize. But in their perspective, right, for them, what is rare is 1 in 10,000, and that means in a median size of state, they can pick up 2 cases each year. And for ultra rare, for them is 1 in 100,000 or 1 in 1 million. What that means is it will take them more than 5 years to pick a single positive case. So like every lab director, if you run a test for 5 years, you did not find any diagnosis, you have to look at it and see whether we're going to drop it or not. So it's pretty fair to let them know ahead of the time. If you screen for a very rare condition, you need to tell them. It probably takes 7 to 10 years for you to find a case, right? You don't want to not able to tell them, and after 5 years, they have to make a very difficult decision. So that is fair. Then the third one is that they need a feasible newborn screening method. So that really goes down to their operations. And most of the newborn screening are done in America is done by biochemical testing. Most of them are on the tender mass platform because they're a low-cost test and it can be multiplexed. You can run 40 different biomarkers with one test. So their budget is 1 sample, $1 per sample per condition. So if you have a same test that you can screen for more condition, then the lab get more budget. So it's a lot easier for them to manage an operation. So that's fair enough. It's good for us because I do want to screen for more conditions. Adding more CDGs to their old galactosemia panel would be good for everybody. And the second, they want a good efficiency. So the gold standard is newborn screening for phenylketonuria. So that screening has a true positive and a false positive ratio of 50. That means you screen for 50 positive PKU baby, and out of 50, only 1 of them is false positive. The other are all true positive. So compare that to our current galactosemia patient. We have a true and a false ratio of 0.11. What does that mean? We screen 10 galactosemia positive. Out of 10, only 1 of them is real. All the other 9 are false positive, don't need any clinical intervention. So in order to make the galactosemia screening more efficient, and we want to increase the positive case. So that works for us because we want screening for more treatable CDGs, and also we want to use functional biomarker so we can reduce the false positive. So that really opened a window for me to put a proposal in that we can help you and we can make this newborn screening better. So the third one is really the big elephant in the room, is everybody excited about the whole genome sequencing. So we foresee this in the future, we're going to do whole genome. We don't need biochemical testing anymore. So 10 years after all this excitement and more pilot study has already completed, what is conclusion? And people start to realize that whole genome sequence for newborn screening has a low sensitivity because of the presence of VOUS. So that's short for variant of unknown significance. So this will be a particularly problematic if you want to screen for CDG, because the easiest mutation, deleterious mutation for us to predict are the severe ones. Nonsense mutation, complete loss of function, very severe amino acid changes, we can easily predict this is a mutation. But for a mild amino acid change, it's very, very difficult to predict, and that is often the most frequent mutations in CDG patient, because two deleterious mutations in a CDG genes are often not compatible with lives. So we can argue that there are a growing percentage of CDG patients carry at least one rare or mild VOUS. So whole genome sequencing for CDG is not going to work well because it's not going to be sensitive enough. So even with whole genome sequencing used as a first tile include VOUS, then we need a second tile functional biomarkers to pick up the real positive. So I think without a whole genome in the future, we still need the functional biomarkers for CDG. So taking all those feedback, and I go back to the pathway and ask a question, in addition to GOT and the CDG1B, can we find some treatable conditions that is old enough we actually know the frequency? So I don't have to go too far, so I just go upstream of CDG1B and PI. There are two conditions there. It's a lot older than CDG. One is called HFI, which is short for hereditary fructose intolerance, and that is identified in 1950s. Another one is rare. It's called FBP1 deficiency. It's also identified in 1970s. So both condition is a disease because they accumulate in fructose 1-phosphate. And fructose 1-phosphate is a potent inhibitor for MPI. So basically they have a secondary MPI, CDG1B, and they can be easily treated by remove the fructose from the diet. So I think these two probably will make the newborn screening people very happy. There are a lot more other conditions that are highly treatable that we want to screen, but we don't know the frequency and prevalence very well. So just as I said, that these are old enough. We have well-established natural history. They easily can be treated, prevented, and the prevalence for HFI is 1 in 18K in UK and less than 1 in 60K in USA. So we're going to get positive cases. And for FBP1D is a little bit more rare. That is 1 in 147K in Italy and less than 1 in 100K in Kuwait. And the FBP1 deficiency is well documented. 50% of those patients present at the first week of their life. So it's a perfect fit for newborn screening. And HFI, the reason that it's such a good treatable condition is not on newborn screening panel is because there's a misunderstanding that those babies not going to present until they are 6 months old or when parents are introduced table food. And that is actually not true because HFI can present anytime after birth. In fact, all 3 HFI child that I get involved in the diagnosis, they are all presented before 6 months old because we actually have a lot of fructose and sorbitol in the medications and even some vaccines. And ironically, we actually give baby 24% sucrose solutions for the pain control. So why we give a newborn that much fructose? Because we want to do a heel stick to make the newborn screening card. So we very much produce a problem on our path to solve a problem. So we do need to screen for HFI. Another reason is fructose is not only introduced from the food, baby actually make fructose. So this is a study in 2011, and they are measuring the blood fructose level in the mom, in the cord blood, and in the newborn. And they actually found the newborn has a much higher level of fructose, even they are not taking it, because they make it endogenous by themselves. Fructose is a precursor to glycerol, so they make glycerol in order to make fat. So baby really need to gain weight, they need fat, so they are making a lot of fructose. So now the question is, endogenous fructose, is this enough to change the glycosylation so we can define them as typical CDG? So I don't have a 24 hours newborn with HFI, but I have a lot of older kids and adult that is on absolute fructose restriction. So my goal is test the glycosylation in them, see whether endogenous fructose actually change the glycosylation. So this is pretty high bar to reach. So before I go there, I go back to our PMM2 CDG studies. We completed 2 really large biomarker studies. One is done in my lab, so we screened 130 PMM2 samples that come from over 100 PMM2 patients. And we found MEM4 is a very sensitive marker for PMM2. And similarly, by Miao proteomics core, they also did a large study with over 60 PMM2 CDG patients, and they found the MEM4 from C4 complement protein is a sensitive biomarkers for PMM2 as well. So it's good that we have 2 large studies, has consistent data. But MEM4 in our hands is not unique. What that means is when you look at the controls, right? This is the blue bars for the controls. So normal people has it too. So similarly here in the other study also found that normal people has MEM4 as well, small amount. So although the amount is small, that can be a problem when we screen for millions of normal people. So can we make it better? So the reason why normal people have MEM4 is because there are 2 MEM4. They are differ by the linkage, so they are isomers. So one MEM4 is what we care. We call it MEM4A. That is produced because of GDP mannose deficiency. So we can make MEM5 from MEM4. That's why the patient accumulated MEM4A. So this is unique for CDG, and none of our normal people will have this MEM4 because we have GDP mannose. We have sufficient GDP mannose for our glycosylation process. So another MEM4 actually can be produced by normal people because they come from trimming. They were trimmed by glycosidase, mostly by alpha-mannose 2 and the hexosaminidase. And these occur mostly in the neutrophil. So we all have neutrophil, so we all able to make some MAN4. Those are normal people, what normal people have. But we can separate these because they have a different linkage for the mannose at the non-reducing end. For the CDG MAN4, we call the MAN4A, it have 1-2 linked mannose at non-reducing end. For the one that everybody has, that's a 1-3 linked mannose. So we cut the story short, we separate MAN4A and 4B, and we can identify the PMM2 or CDG specific MAN4A by using 1,2 alpha mannose digestion. So when they are sensitive to this digestion, then we know this is MAN4A. So once we separate them, we can find nothing in our controls. So this is very unique markers. We can find the level very, very high in PMM2. So now we have biomarkers that is highly sensitive and highly specific. So now we are ready to look at DBS that is collected from HFI, GOT, MPI, and PGM1 patient. As we show here, we have one infant that picked up accidentally by whole exon sequencing, because this is a frequent condition, and the baby was not symptomatic for HFI. He was exclusively breastfed. And he actually has a very high level of MAN4. So we have 5 patients at that time that is on absolute fructose restriction. They are in these patients, so I think they are very good, very compliant, and they have a low level of MAN4A. And we also tested GOT deficient patient and PI patient, all have MAN4A very highly elevated. So compare with these conditions, they are 5 to 10 times higher than HFI patient who's only have endogenously produced fructose. We also have additional markers. This is also a unique marker only presenting CDG. That's a glycan that don't have mannose at all. And we can pick those in HFI, GOT, and MPI. And we also tested 4 PGM1 patients. They all have elevated monogal and monocyte ratio. So we were able to collect these preliminary data to submit for a newborn screening grant proposal. So after the grant was submitted, I was able to collect additional 10 HFI patients post absolute fructose restriction, and all of them has elevated MAN4A. So I was able to convince Andrew that HFI indeed is is a CDG, and hopefully we can welcome our HFI family to this big CDG family. So I do have a colleague that at Kuwait, so she sent me 12 FBP1 deficient patient samples, and we found all of them has increase of MAN3, MAN4, and 92% of them actually has MAN4A increase as well. So I'm convinced that FBP1 deficiency is a CDG as well. So next, I'm going to talk about MAN4A in GMPPB CDG. Since we have this highly sensitive marker, so we were able to look at patients with GMPPB because those patients are often very mildly affected. So our index patients are 11 years old girl. That's again Andy's patient. She came with increased CK, that's come from the muscle breakdown. And this is her level before the mannose supplementation that is quite elevated. And 2 years after mannose supplement, and the level is reduced pretty close to the noise level. And the kid grown up and went to college and then take the manuals, of course. Then she get into trouble and come back and test it again, and her level go up. And the more recent visit, she's still not on manuals. Her level is consistently up. So we're very convinced that this is a good biomarker for GMPPB. And these findings really helped us when the second case showed up from Canada. So this is a 5-year-old girl with similar story, but even milder than our first patient. And we were able to confirm this biomarker indeed is increased. And because of this, and the family opted for high manual supplement. So in summary, and N-glycan biomarkers can improve galactosemia newborn screening. We can replace, hopefully, our current enzyme with 4 to 6 functional biomarkers with very high specificity and reduce false positive. We can add HFI, FBP1, MPI, PGM1 CDG to the same platform that will save lives and we make the traditional CDG screening more efficient. So with functional biomarkers, we can also pick up secondary newborn screening target. So this is a shortcut for newborn screening that is done for free. You have primary target, which everybody pay for it. That's the taxpayer money. But for the secondary newborn screening target is basically you got it for free. Then the criteria is much lower. You don't have to have treatment right now. So as a secondary newborn screening target, we can do PMM2, and we can do most of the type 1 and type 2 CDG that affect N-linked glycosylation. So the next, I hope I have time to
we're going to have to move on.
We don't have to move on. Okay. All right. So I'm not going to talk about A2, but I would like to thank my lab, all the people who really did the work. And I would like to thank CDG Family Group. And I'm really grateful for all the parents, CDG parents, and I'm grateful to Andrew for all your support. This cannot be done with your help. Of course, big thank you to Andy and most of the patients I present here, Andy's patients, and Michael Gelb, that's my collaborator, who put this grant proposal together. And that's the end of my talk. Thank you for your attention. I'm ready for your question.
Great.